a little bit about myself um, before we dive into the topic. I've worked in healthcare for over 2 decades. I started on the benefits side in a specialty pharmacy. I worked at CVS Health. I was the subject matter expert there for them in their specialty division for their Medicare products, which led me to my next role in healthcare as a provider outreach and education specialist for the Medicare DME MAC for regions A and D, Noridian. And sorry, let me go back. Oops, wrong button. Keep doing it. And now I am the Director of Program Management at a specialty pharmacy overseeing their gene therapies. So just to start in, basically, we're just going to kind of go over mostly benefits verification and kind of some high-level tips. We're not going to get into sort of the weeds of verifying benefits and what you would do to, to transition the patients to a site of care. Not like, not low level, just sort of high level, but things that you would do to transition. So the first thing, when you're doing the benefits verification, the way that I always explain it to my teams is sort of like you want to be almost like a private investigator. So you want to do the who, what, when, where, why, and how. These things need to be in the patient's medical record in order for the patient to transition to a site of care. Any specialty pharmacy, any transitional site, anyone who wants to get a prior authorization for this patient for their medication is going to need this information. They're going to need to know, whose name the insurance is in, the relationship to the patient, if it's the primary insurance, if there's a secondary payer, a tertiary, they're going to need that same information for each payer. They're going to need to know, obviously, what drug, the dose, frequency, route of administration, how it's measured, if that's micrograms, milligrams, if it's per single unit syringe kit. They're going to need to know when, what's the anticipated transition date, where, so when treatment is initiated, what that transition site is going to be, and if there's a difference in the states for the locations. So if, for instance, the patient's in your hospital in Pennsylvania and they're going to go to a nursing home in Ohio. So there's going to be 2 different states there. Are you going to need a physician in the new state to write for them? Are they going to need license, or they're going to go home to Ohio? Are you going to need a prescriber in Ohio to write the prescription? If they're going to have home infusion in that state, is that nursing agency going to accept a prescription from a prescriber in Pennsylvania? So you kind of need to know all of these things before anyone can get the authorization in place. The why is going to be your condition, your ICD-10, and if there were any step therapies or alternate treatments that were trialed and failed. And then the how is going to be, will the patient need a nurse? Will they self-admin? Is there training that's going to be needed? So again, a lot of these, they're going to be in the patient's chart, but you just want to make sure that it's very, very detailed, very outlined, so that all of that information is available so you can transition the patient to the site of care. Considerations when transitioning. Here's some things that can kind of be a hiccup. Limited release drugs. So sometimes drugs are only available as few as 1 to 4 pharmacies. A pharmacy might have access to a drug, but only for specific types of care. So they might only be available for long-term care dispense, but not for dispense to a rehab or a home infusion setting, or vice versa. So you might be told that that pharmacy has the access to that drug, but they can only do it LTC. If you're not sending the patient to a long-term care, then that pharmacy actually can't dispense for the patient. So you're going to need to find out who can dispense the drug for the specific site of care that the patient is going to. and how the patient is going to utilize the product. Site of care considerations. Transitioning a patient is limited in scope by which insurance site that can service the drug and bill, and the type of site the patient needs. So again, aligning those for each patient. It's always a very delicate balance. It's going to be verify, verify, verify. We consistently see patients in the field that are transitioned, and they thought that, a specific pharmacy would have access to it, and the patient kind of gets sort of like in a no man's land for a while, where they're, out there without drug, and they kind of do like a pharmacy shop for a while, where they tried the next pharmacy that was on the, next list of in-network pharmacies, and then the next pharmacy. And like I said, very often, this is their preferred, but their preferred doesn't have access to that drug. And well, this is the next preferred, but that preferred doesn't also have access for this specific state. Well, and this is the next preferred. Well, that one doesn't have nursing in the patient's area. So you kind of have to really verify each of these details to make sure that they align with your patient for that specific site of care and for how the patient is going to have this drug. So making sure that all of those are aligned before the patient's kind of released is really important, because sometimes the patient can go months without drug if those details aren't aligned in the beginning. And especially when they're coming from the hospital to a home site, even to a nursing home, we've seen it very often where patients and other care providers won't call back in to the hospitalist or the specialist that sent them to the alternate site. So they won't call back in and say, hey, I've been here for like 90 days and no one ever got me the drug. So it's very often that the patients won't self-advocate when they're just kind of like out there in the wild, because they are getting updates from wherever they're at. And those people are telling them that, well, you can't get it. So they're not going to be reaching back out. Insurer policies. Determining the key factors that the insurer uses when outlining coverage, that's going to help you guide the patient so that the site of care experience coordinates best for their needs. This coordination can help prevent unnecessary start of care delays. It can also assist prescribers and discharge planners by preemptively lowering the patient's risk factors that left unchecked, it can lead to the lack of therapeutic adherence. And that, again, is mostly like the things that we were discussing where, for insurers' policies, it's more so where you're going to find very, very weird little glitches. So sort of like the site of care issue with insurer policies. Say, for instance, a patient had to trial and fail a specific product. Very often, all you have to do is write a letter of medical necessity. The patient came into urgent care in, cardiac failure. So we weren't going to trial and fail anything. We're going to start immediately on this drug. Or the patient had stage 3 cancer. So we're not going to trial and fail anything. They're going to start immediately on this product. That's enough to get them past that policy. But if you don't have those singular statements in the medical record, they can be in, months-long prior authorization denials. And you think that you've avoided that because you already got them authorization in the hospital. But a different authorization is required for the home, and they will pretend like they didn't receive any of that information from you when you got the authorization in the hospital. So now when they're in a different alternate site of care, someone's redoing prior authorization, the insurance company will pretend like they've gotten no notification of any of this before. So you've also kind of got to make sure that all of that notification, all of that information, and you might have even done it peer-to-peer. So this might have been verbally that you affirmed these things to an insurance company. You might need to just write that down and send that to whoever the next site of care is, so that the patient doesn't go through that sort of downward spiral where they no longer have access to that drug. Because again, the insurance, even if the patient's been getting it for weeks in the hospital, that will be one of the key factors that we see where they no longer have coverage. Patient deal breakers. This is also a consideration that we often overlook. This can lead to several site of care changes. We should pay close attention to these. Some are preferences, but some are factors that are unchangeable, but they can impact care. So one of the things that you'll notice, patients have like a disposition. All of us do. So some people are very quiet. Some people are very loud. Some people are very boisterous in the way they talk. Some people are not. Some people are, all of us have like these little things that we do. If you're going to have someone come into your home on a weekly basis or a biweekly basis, you're probably going to make sure that they fit with you, with your home, with how you get along with them. What if you're not a dog person and they come in and they've got dog hair? What if you're allergic to dog hair? So just sitting down with the patient and going over like, what's a deal breaker for you? Because one of the things that we see in the specialty pharmacy is the patients, coming in and then just going through nurse after nurse after nurse for deal breakers you didn't even know they had in advance. So it's like, they don't want dog hair. They don't want someone who smelled like cigarette smoke, or that person cursed too much. And you're like, if we had like a list of deal breakers in advance, we probably could have vetted this a little bit better. So just kind of finding out like, hey, this is sort of the personality, fit that this patient is. And we want to make sure that we've got a good fit on your end too, so that we're setting everyone up for, a good match, sort of like a dating game, but not. But they're going to spend several hours with you. We want to make sure you get along. And then special considerations. These are things that are just unique. They could be the nursing agency requirements, special requirements of the drug itself, or it could be the condition created because of a combination of those considerations. So one of the special considerations that you can think of, right off the top, nursing agencies. Some specific nursing agencies require certain things. So one of them off the top of my head, certain nursing agencies will require that a patient has X number of infusions in a clinic setting first. So some of them are, 3 infusions in a clinic setting. Some of them are 6 infusions. Some of them might be multiple months of infusions. If your patient's coming from a hospital setting, they've probably had these infusions in a hospital setting. A, making sure that you have documentation that they've already had some of these in a hospital setting. It's very important. And then B, making sure if you're not going to be able to utilize whatever that requirement is for that nursing agency, that you go with a different agency. Some agencies require in-state orders, even if that's not a requirement of that state. So again, maybe if that patient can't see a prescriber in that area because of the disease state, or, the patient doesn't want to travel and see another doctor, or their insurance, then maybe a different agency is required. Because often those kind of special stipulations can be, again, one of those things that you trip over, and you just kind of keep tripping over it over and over again, that you really could have avoided if you had known in advance that that agency requires this and you don't have it. You could just went with a different agency. So making sure that you understand the special stipulations, special considerations, the drug itself. Some drugs have unique considerations. Some drugs require specific testing. Now, if you're going to send your patient to a nursing home, and the patient has to have a specific type of blood work done each time before they can have the drug. So if they have to have the blood work done every 30 days, and they can't have the drug unless they've had the blood work done, setting up that blood draw and making sure that someone is coming in and taking it and registering it so that the patient can have the infusion, it's highly important, and making sure that you coordinate that with that site so that they know this has to be done. Because we've had it happen multiple times where the site of care is like, no, they get this done at the first of every month. And you're like, well, that can't work because it has to be done at this cycle so that they can have the infusion. So you just making sure that you coordinate with these entities so they know that these things are required for these infusions. Again, little hiccups that we run into where patients are, going into a drug desert. And sometimes we've seen patients go for months without drug, specifically from, little issues like that. Oops, went the wrong direction again. I think I have it backwards. Solutions. Sorry. So the first solution, of course, do the research. There are several steps. So just checking in with the patient, the insurer, and even potentially with the site of care to ensure that it's a good fit. Just put in the effort and you'll be rewarded with the continuity of care, lower readmission rates, happier, healthier patients. I mean, it's what everyone's goal is, so we all win. Use your village. Do not be afraid to reach out to the advocates that you meet here, ones that you know, people at your facility, anyone, patient case managers, people at the drug manufacturer, contacts you've made from, previous roles, just anyone that could help you. There's a ton of medications out there. There are so many variables. The different sites of care bring in multiple variables, patients' disease states, and where they're, where they are in their health, their chronicness of their disease, how well they're able to be maintained. All of those bring in new and more challenging variables each time. Just if you run into a situation where you're like, gosh, I don't even know how to fix that one, making sure to reach out and just ask for someone to help you advocate for that situation, or, how would you navigate this one? And then coordinating the care handoff, ensuring a seamless handoff with the entities involved to the degree that you can by sharing and coordinating, just providing that who, what, when, where, why, and how before the discharge to ensure that the patient successfully received is vital. Timely responses and coordination with the prescriber and the site of care to obtain any other needed information. That just helps your patients stay on track for that winning initiation of care. And then using the fillable checklist. So there are 2 free PDF checklists that are available that we have for the attendees. And I can bring them up too in a second just to show you. And there's basically, I think I can bring them up. I'm not sure. So I say I can. I know I saw them on here. But basically, they just show you, you can fill them in and put in what your patient's benefits, the what, when, where, why, and how, and it kind of gives you like a breakdown so that you can track where the patient's going, any, possible things that you've encountered so that you have a way to check that off, and gives you some little tips on the side of things that might be a problem at that site of care. So just sort of a little a way to help you track and potential pitfalls that you might run into. And then the other checklist is just some common site of care considerations, and it only focuses on a home infusion. So that one's just for home infusion, and it has some common pitfalls so that you can make sure that you track for that one. But the first fillable is just for the benefits verification, and it's for all sites of care. And I talked way too fast, I think. So I am already done.